to have been given the duty of welcoming you all to this webinar. We all know palliative care, and it's a team work actually. And the palliative doctors are considered to have the touch of God. And I'm sure our faculty for today, Dr. Sreedevi, would touch upon all those aspects. Though palliative care consists of a team of doctors, the role of dentists is not clearly come to the field. Probably in certain hospitals and all, definitely the role of dentists are being recognized, but in private care, in private practice, probably Dr. Sreedevi would be giving us more insight into it. Without wasting much time, let me get to my duty. I would like to welcome the chief guest for today, our energetic CDH chairman of Kerala Dental State, Dr. Sreedevi Warrier, to this webinar. Firstly, welcome, dear Dr. Sreedevi. I hope he has joined us. Okay. Let me move on to welcoming the speaker of the day, our faculty, Dr. Sreedevi Warrier. Thank you, ma'am, for taking your time out in spite of your busy schedules and your work to be here with us today, to be enlightening us dentists on the role of palliative care. Welcome, dear Dr. Sreedevi. I would like to welcome all the office bearers of various IDA branches and all the members of Indian Dental Association to be part of this webinar. And thank you to all of you who have come here and spending your time. And we all welcome you to this webinar. Thank you.
Will I start my presentation?
Ma'am, I would like to invite Dr. Georgie George, IDA Guruvayur, for introducing our faculty. Dr. Georgie George.
Doctor കേറിയിട്ടില്ല എന്ന് തോന്നുന്നു. Ma'am, can you please start?
Yeah, sure. So I'll start sharing my screen in a moment. And before that, I'd like to thank for contacting Pallium for such a webinar, that showing that interest to understand the role of dentist in palliative care, or to understand palliative care in detail. So when this came to our team, I told maybe I'll be the ideal person to talk about it, because as a background as a dentist. So I'll introduce myself. I'm Dr. Sreedevi. I am associated with Pallium India or palliative care for last 11 years now. I've done my dentistry from Government Dental College, Kozhikode, in the 2002 batch. And practically after that, I've been associated with Dr. Raj Gopal and various other projects. Currently, I'm heading the Education and Skill Building Department, where we host so many courses for doctors, nurses, and allied health workers across the country and abroad. Around 21 countries, we are hosting training programs. I'm also a tutor in School of Medicine, Cardiff University, UK, for their postgraduate program in palliative medicine. So I am just curious to know what palliative care mean to you. I'm so sorry to ask. I might be asking a lot of questions probably. So it will be good to know what palliative care mean to you. Either you can talk or you can type it in the chat so that I can just get an idea of, many of you are already involved with some kind of activity, but good to know from here. from
Hi, Dr. Warrier. Myself, Dr. Sebi, State
Yeah.
CDH Chairman. Actually, we found a lot of gap in taking care of homebound, terminally ill cancer patients, oral care in oral care. So, what we are trying to achieve with this project is actually to fill the gap and create a unit in every branches in Kerala who is ready to go to homes and do the necessary care for the patients.
Thank you, Dr. Sebi. I'm taking a few words from that is bedbound terminally ill cancer patients. Any other words that anyone wants to add to that, which can be linked to palliative care?
Anything that relieves pain?
Yes. So I'm taking
Probably
the word
that-
pain relief there.
Okay.
Yes, right. So without, I got at least 2 responses, so I'll go ahead from there. So that's absolutely right. It involves cancer, it involves terminal care, it involves a lot of pain management. So I like to share a story of Mr. A. So Mr. A was diagnosed with head and neck cancer, and he was on. So what happened is that he found the lesion. He had difficulty in swallowing. He consulted a nearby doctor, and the doctor told that there is a growth. Probably we may have to refer you to regional cancer center. So he was referred. He went there, and then they told you have to take. He actually underwent the biopsy, and then came out that he has cancer. So they told you that you don't have nothing to worry about because it's beginning and it is treatable, but you have to undergo minor surgery. You have to undergo radiation, and maybe after that we have to go for a regular follow-up. Hearing all this, he got scared. He came back home. He did not go back for treatment anymore. What happened is that the lesion progressed, and he was unable to swallow, unable to sleep due to pain, unable to go for work. And then he went back again to the hospital telling that I have severe pain, I can't eat anything, I can't sleep, can you do something? Then obviously the typical answer from any hospital would be what we told you from the beginning. It could have been treated then. Now it is beyond particular treatment. What we can do is that we can put in a tube so that you can swallow without any problem, and your medicines can be given through the tube because there is no other treatment that can be offered. His family had his wife and 3 children. He has an elderly mother also at home, and he was the only breadwinner in this particular family. So this is one scenario that probably Dr. Sebi mentioned about that cancer, and Dr. Joseph told pain, and probably looks like he is very cachexic. Probably he is not able to move much from the bed. Any idea that? So we went for home care, and we asked what is bothering you the most. So any guess or what would be the major issue that he might be facing? What is the first thought that goes into our mind when we see a patient like Mr. A? I'm sure most of you might have seen at least during your graduate or postgraduate education in these kind of patients. So looking at him, what would be the first thought, first issue that come across in your mind?
Is that about the patient side?
Yes, patient side.
Enjoying
What
the
can
food?
be the possible issues? Yes.
He is finding it very difficult to enjoy his food, and maybe I didn't get actually what was your question.
So the question was, what can be the issues that can be faced by Mr. A?
Oh yeah, first thing is enjoying the food. I mean, having food because of pain and inability in that area.
But anyway, he is having a tube, so food is going in.
Okay, all right, okay.
Food is going in. His hunger is addressed.
Okay, cool.
But there is a point in what you mentioned, but I'll come to that later.
Mental trauma.
Anything else? Yes.
Mental
yes.
trauma.
Yes. Why mental trauma, Dr. Anju?
Mental trauma because he can't. He is the breadwinner of the family, right?
Yes.
So that
So he
makes,
can't go for job.
yeah, he can go for the job. He might be thinking more about the future.
Absolutely.
So in that sense, I
Absolutely.
guess palliative care, psychologically we can
Yes.
support, right?
Yes. Absolutely. Any other comments? I'm checking the chat also if you have anything. I can see finance support. Yes, I think that's mostly what we can do. So we usually sit with the patient and ask them what is bothering you the most. So the first issue that he brought up was, will I be able to pay my medical bills? Because now I have to go for changing my tube, for reviewing for my pain and everything. Who is going to pay my medical bills? So we can argue that the treatment given in government setup is free of cost, but going to that particular place needs a rickshaw or an ambulance or at least a scooter. You need someone to come with you who has to be out of their job. Either their kids have to accompany. You need someone to carry you from the house to the vehicle, from vehicle to the medical college, and we all know how medical college system works. You literally have to hire someone to pull your wheelchair. So he's worried about that. How am I going to, so someone just now mentioned, how am I going to provide for my family? Because he's completely unable to get out of his house. He's kind of bedbound. He's not lying down, but he cannot move out of the bed without any support. I don't want to eat or talk. So, what mentioned during that he cannot eat. So through the tube, he's being fed. But imagine he cannot taste anything. He cannot feel anything. Everything is in the mixer, either milk or something soup or something is going in, but he's not unable to taste it. He's unable to have food with his loved ones. So what happens if there is a patient like this? We'll feed through the tube first, and then we come and eat our food. And he's dependent on. So eating food, we all take for granted. We can all eat our food. But what happens to him? Even for eating food, I have to depend on my son, who should come and feed through the tube. That also I cannot taste. I can see everyone eating, chewing and eating, and I cannot do that. So that brings in a lot of mental trauma to patients, that even if they are hungry, they don't prefer to have the tube. And comes the pain part. There is so much of pain. So he literally has not slept for weeks to months because of severe pain. He went back to RCC thinking that he will get some pain relief, but with the medications that he was given, what is the usual conversation? I don't know how many of you are familiar. It is usually told that you're bound to have some pain. This is a disease like that. This is a very common response that is being given when you ask for more and more pain relief. I'm unable to sleep. I cannot sleep because of severe pain. All these thoughts is actually hindering my sleep. So these were the issues that he was mentioning, and very commonly asked question: am I going to die now? I can understand that I'm losing my weight. I cannot eat. I'm on so many medications. I cannot sleep. Am I going to die? And he's completely unable to, he has socially isolated himself. He doesn't want anyone to visit him because this is not how I want others to see me. I don't want them to see me with a tube in my nose. So he never bothered to get out of the room. He doesn't allow visitors to come inside also. He was in severe mental trauma. It took a lot of time for him to start talking to us actually. So pain is not something physical, as someone mentioned. It is psychological, because he's thinking about his family, what is going to happen, how long do I have, what is there to plan, who's going to take care of my children, who's going to take care of my mother who is elderly, and she may need some medical help, who's going to take care of that. Socioeconomic, how am I going to manage my medical expenses? I cannot go out and have a conversation with a relative. And how many of us will invite a person like this? If suppose you're having a marriage function in your family or a get together, how many of us will be okay to invite these kind of patients? Someone who is having a tube or a tracheostomy, people don't think them as normal. And they themselves don't want to get into such crowd because it is so embarrassing. And after all, there is always a spiritual element. When I say spiritual, it is not always related to God. Sometimes people start asking questions like, why am I being punished? Am I being punished for something I did in the past? It is all karma. I did not pray enough, or I did not do much of a church visit or a temple visit. Am I being punished? It is not just God related, but existential crisis. Why am I just being alive? I'm so dependent on others. I'm being a burden for others. Why am I just alive? I should be dead. So that also comes under the existential crisis or a spiritual distress. So, I'm explaining the story of Mr. A here because illness-related suffering is much, much more than a physical distress. We see physical distress as a top of the iceberg. We are not seeing what happens underneath. So illness-related suffering is not just a physical distress. So with that, I am going to what palliative care is. This is a recent definition of palliative care or a consensus statement in 2017. I'm not going to read the entire sentence, but I want you to notice these words like holistic. So it is not just giving some medications, but it is taking care of the total care of that particular person. Then I have highlighted SHS. SHS means serious health-related suffering. So it is not just cancer. Serious health-related suffering can happen to n number of illnesses. It can happen when you have people with Alzheimer's, any neurological, progressive neurological illnesses, people on wheelchair after a road traffic accident, quadriplegic, paraplegic, children born with anomalies. So anything causing suffering because of health-related issues should come under palliative care. And it is not just taking care of the patients. Along with patients, their family members, the immediate caregivers, everyone is going through the suffering. The wife of Mr. A is clueless how to feed. I mean, how many of us know how exactly to feed through a feeding tube? I was not confident how to prevent the air bubbles, how much quantity to be given, to flush after each feed. I mean, how many of us know about it? And these are people from a very normal background. So the wife is completely scared to feed through the tube. And how can I do that? How can they shift patient's position? How can I help him to get up without pain? So the wife is going through a lot of mental trauma. She knows that the husband is dying. There is no income in the family. The children cannot go to school. So it is not just the patient who is going through the suffering, but it is also their families and caregivers. And it is not just palliation or giving terminal care. It includes prevention. Understand, okay, I know that Mr. A, whenever his cancer is becoming incurable, or Mr. B, who has had a stroke, I know that he is going to have a suffering. He's going to be bedbound. He will find it difficult to turn his position. He can have bed sores. He can have problems in his catheter. He can have constipation. So how to prevent those suffering? How to understand early identification? How am I going to manage when this occurs? So that is how palliative care works. And it should go along with their disease-modifying treatment. Suppose Mr. A is having a stage 1 oral cancer, which is completely treatable. Still, he has issues. Still, he has questions. Why oral cancer? I have not chewed any tobacco. How did this happen? Or I severe pain. So all these issues will happen even if the cancer is curable, even if the stroke is recovering. So addressing the issues, even if the patient is going to go through a curative treatment, help the patient to live fully as possible until death. So everyone, I have heard so many people telling, anyway, they are going to die. I mean, they will die only when they die, right? Till the last second of their dying process, they are living. They are living human beings. There is a lot of things we can do. We celebrate birth like anything, right? When someone is born, families are there, providing everything. The baby needs a lot of care. The mom needs a lot of care. The same way, when someone is dying, they need a lot of care and attention than when they are living, actually. It is applicable throughout the course of illness, depending on what the patient needs. And it can be combined with your disease-modifying therapies. Even if you are treating cancer, even if you are giving radiation, or even if you are treating the stroke, even if you are treating the other illnesses like kidney disease, it can be provided in conjunction with the disease modifying process. And it is not about dying. I always say when someone asks me, are you working with dying people? It is not about dying. It is about life. It is about giving life for people who are, none of us are immortal, right? So it is all about giving life. It is not about dying. It is help them to live with dignity and die with dignity. So as someone mentioned in the beginning, there are huge gaps in the care. In our country, only 4% of people who need palliative care have any access to it. In Kerala, the picture is very different. 83% coverage in palliative care, like in health system, is very strong. Palliative care, Kerala model is one of the best in the world. But in other parts of the country, only very few people have access to palliative care. And we have to understand, as dentists, palliative care is not just provided by specialists. Even a trained volunteer is providing palliative care. Like they have their own roles. ASHA workers are giving, nurses are giving, then why not dentists? So it is like basic life support, right? We all learn BLS. Every specialty, irrespective of you are a dentist, you are an emergency physician, you are an oncologist, general medicine person, we have to learn basic life support. So this is something that everyone should do. Everyone should have the skill of palliative care. So to understand which all illness, why I'm talking, it is not just in cancer, because they say the number of serious health-related suffering by 2060, you can see it is not just about cancer. It is about HIV, congenital malformations, tuberculosis, chronic kidney disease, chronic heart disease, injuries, liver disease. Lot of illnesses are coming into picture when we talk about palliative care. It is not just about cancer. It is not just about bedridden patients, and it is nothing to do with death. It is about giving life, helping people to affirm their life. So what happens is that when I started working, I accessed like what is the role of dentistry? What can we do? So the thing is that apart from all these issues, these people has a major issues in their oral health. And this oral health has a major impact in their emotional issues. Suppose this Mr. A, he's not feeding through the mouth, right? So you can imagine, and because of the medications, how the oral cavity will be. He doesn't want to talk because there is a foul smelling wound. He will not open his mouth, although he wants to talk. And many a times, it is the first site of pain and loss of function in palliative care patients. So a thorough examination is mandatory at any stage of illness. And it is not just because it is not just confined to end of life care or cancer care. So when people talk about role of dentist in palliative care, okay, oh yes, there are a lot of head and neck cancers. When I used to ask them, I don't think people with head and neck cancers only have the oral issues, right? It is the oral problems are not just confined to head and neck cancers. It is there in non-cancer palliative care patients also. I still remember during my undergraduate days, when I was doing my internship, we got a reference from the medical college from a stroke patient because he was having stroke, because he was hemiplegic. The oral cavity, the mouth was open on one side for a long time. There was no caregiver for him. He was kind of neglected patient there. So he started having maggots. Then I realized, okay, it is not just cancer. It is also for non-cancer. Oral cavity is there for everyone. So people, when they ask, oh yes, you have a lot of scope in head and neck cancers, I always say, no, it is not just head and neck cancers. Every patient has oral problem. Any patient, any diagnosis coming to palliative care. And it is very important because a person like Mr. A has a lot to communicate to his family, right? He has to talk to his children. This will be the last few weeks in his life where he has to talk to his friends, his children. He has to talk to us. Okay, doctor, I'm having pain. He has to smile. He has to give a last kiss to his children. Everything needs a pain-free oral cavity. So it is very, very important in terms of when we talk about dignity till dying. Then I searched, I understood that there is even a definition for palliative care dentistry, which was quite surprising. And this definition came in 2006. Still, many of us are unaware. So, and they say that for anyone, any advanced disease, whose oral cavity has been compromised by either by disease or disease-related treatment. And we all know the impact of treatment which happens to the oral cavity, irrespective of the illness or the diagnosis. So, a few questions. Suppose in your practice, you are seeing a suspicious lesion on a tongue, and the person tell you that there is a history of tobacco chewing. You kind of know that it can be an oral cancer. And what will be the response? And we'll go to the other questions later. When you see that lesion, you know that possibly this can be cancer. What will you tell the person? Or I can modify the question, is anyone confident to talk to the patient about the suspicious lesion? Are we trained to talk to the patient?
Yeah,
I don't know, some of you might be trained. Yes. Yes, Dr. Andrew.
We will tell the patient that you are suspected. If the patient is having a habit, then we can clearly translate him that you may have this kind of thing. So we will advise him to go for another higher end or like to oral pathologist or oral medicine.
What will you use? Will you use the word cancer? Sorry, I didn't hear the last part. Sorry.
Actually, we should know.
Having an habit. If he's having a habit, what I feel, we have to disclose. Because if you don't disclose about the word cancer, he will simply say that okay, he may feel for to look for another dentist. He may just skip, and we don't want the patient to skip.
To miss out on the treatment, right? On time. I completely.
Oh yeah, we don't want to miss out. We don't want to miss the patient treatment. So we will first call the patient bystanders, and we will make them convinced and make them confident that just rule out the thing. Rule out, then there is no issue. But if you don't say anything, we say there's just only suspicion. Patient easily they will skip. Patients are normally, what I feel that they're normally scared of treatment.
Yes, so, especially with dentists.
So it's our duty to convince them that you have to check whether it's cancer or not. If he's having a habit.
Yes. Dr. Sebi, you were trying to tell something?
Actually, I might take a different route actually. As Dr. Anju was saying, I would call both of them and tell them we could see some lesions in your mouth and it is not normal. And we need to rule out the issue with an expert. So probably we'll have to do some kind of test to see it. And that is the best way to go forward, because if the ulcer is not healing for a while, you will have to. Initially, we can say that. And if the ulcer is not healing for 2 weeks, definitely you need to go for a biopsy kind of things.
So both of you agree that we need to tell the patient and the family member and then make them understand what is happening with them. Is it easy to communicate with them? Are we comfortable if they cry, if they are angry, if they just get up from the chair?
Breaking the bad news is always a trouble, but we need to train it, and we need to understand that the reaction would be unexpected reactions can happen from them. I have one of my friend what happened to him is he openly said it seems like a cancer, and the patient came out and kicked his face. Came here
that is where our intention is good. So what we think, we don't want them to, we want them to understand. They should understand what is happening. We should be very open in having the conversation. But how to communicate is very different.
In an empathetic way, understanding the emotions and as you said, the holistic element, the all spiritual, mental, all aspects and family aspects. When you say bad news to them directly, they may not be accepting it at the first place. So we have to train it. Actually, we need good training for that, the breaking the bad news. Yes.
Thank you, Dr. And again, next thing is, usually they say I have severe pain. Okay, I understood that I need to go for test, but I have severe pain, unable to sleep. What happens is that we usually stop probably in the maximum, we would go till ultraset, nothing beyond that. So even with ultraset, patient is telling that still I have pain, unable to sleep because of severe pain. You're kind of stuck there, right? You may not be able to go beyond that. I don't know how many of you will go beyond uh, that, because I'm not blaming anyone, because we are not trained in doing that. And then suppose they start sharing their concerns about the lesion. Again, we are stuck. I mean, what all to be told, how to communicate, with whom we should communicate, whether the patient is able to take it, what will be the reaction. I mean, a lot of things can happen. And then very often they say, what should I do now? Should I die? I mean, I have with oral cancer in all the movie theaters, they show all these pictures. Am I going to die like that? So all these questions can come, and as you rightly pointed out, none of us are trained to communicate. We are trained to take them as long cases. What I was doing, I'm not telling everyone did the same thing, but this is what I used to do. Any patients with oral cancer, good, long cases when you are a student. Yes, I got a long case. And then you're worried about the case description, like how much is the lesion, whether it is indurated, what you feel, whether there is a bleeding, whether there is an ulcer, whether you are going for biopsy. So all this curiosity will come up. I've never ever thought about their suffering. I've never seen the person behind it. I was very focused on that particular lesion. It is just an oral cancer. I mean, maybe I was different. I did not address any symptoms. So they used to tell pain. Yes, we could give some analgesics, whatever we knew, but I couldn't go beyond an ultraset. After ultraset, even if they are telling pain, I mean, I was completely helpless. And I am sure my seniors, my professors, none of them have gone. I have never seen anyone going beyond ultraset. There was no option. I did not know that I'm supposed to manage pain. I know that it is the oral cavity that I'm supposed to take care. I have to do timely referral. I have to send them to oral pathology or facilitate their visit to oncology. I did not know that I have to manage or listen to their symptoms. I did not know that I have to listen that, okay, I have 3 children at home. I'm a daily wage worker. How am I going to live? I did not know. So generally, I stick on to the safe questions. How is your pain? How is your when is your date for biopsy, etc. It's very safe, closed questions. Nothing more to explain, nothing more to listen. I never asked beyond that because I did not know how to handle. Then, as I studied in Calicut, we have 2 weeks of posting in the Department of Palliative Medicine, which is the IPM, Institute of Palliative Medicine. 2 weeks mandatory. Everyone told us that it is a good posting. No one bothers whether you go there or not. Just go there, sign your attendance, and go out, etc., etc. So with a lot of expectations, we went there. Then I happened to see the same patient which I saw when I was doing my 3rd year in oral medicine. I saw the same patient there getting pain treatment after his curative treatment. He was pain-free. I remember his face very clearly. He was crying in pain. He came behind me several times asking for some pain relief. I was clueless. I told, I cannot do anything. You have to tell your oncologist about your pain. He kept coming back because I was the first person who saw him. I told, oncologist is supposed to manage your pain. I tried to avoid as much as possible, but there I saw all of them were pain-free. And everyone is, even though, so when I look at their case sheets, they have terrible diagnosis, end of life situation, progressive cancer, but all of them were comfortable, pain-free, and the way they talk to their treating doctor, talk to the team members, I became so jealous. I decided I want to be that doctor. I don't want to be the current one. I want to be that doctor where patients feel comfortable to talk. I should be able to leave them pain-free. They should be able to tell me what all happening in their life, and I should be able to find solutions for that. So then I started searching what to do. Obviously, at that time, I couldn't do the training from IPM because parents did not want me to get into palliative care at all. Then I kept searching, and these are the courses that it is open to dentists. IAPC, Indian Association of Palliative Care certificate course is open to dentists. And other courses, we have 10 days foundation course in Trivandrum. It happens in Thrissur also, many of the offline courses. There is a 6-week certificate course. There is a 1-year fellowship course. There is one postgraduate course in UK. And under Pallium India, we run online courses for dentists. Most of these courses are open for dentists. So what did I do? I just came to Pallium India. I met Dr. Rajgopal with a lot of difficulty. I could get an appointment. I told, I want to do something. I want to become a palliative care person. I just don't want to do anything else. Please find a place for me. So I started volunteering at Pallium India. Meanwhile, I did their 6-week certificate course and I joined them. Then everyone started asking, what are you doing here? I mean, what is it that oh, head and neck cancer, what are you going to do? Are you going to treat head and neck cancer? So a lot of questions were asked. I myself did not know what I'm going to do. As someone mentioned in the beginning, there is a lot of lack of clarity is about our role. I did not have any clue. I thought, but I told everyone has oral problems, so I'm going to do something. So to understand the depth of the problem at that time, I did a need assessment study. I just examined everyone's oral cavity for a period of time, whichever patients come to OP, and I understood and to understand what are the problems that they are going through and how it is related to their diagnosis. So by the time I joined my 1-year fellowship in the, so this was a part of my need assessment, my fellowship. So I found that it is not cancer. Patients with non-cancer, patients with other than cancer also have a lot of problem. Obviously, cancer in the oral cavity has a lot of issues. Like 60% of them had problems, 76% had problems like pain, dry mouth, chewing difficulty, they can't swallow. And some of them even told me that the oral problems are their only problems. Some, I still remember some of them told at night I'm unable to sleep because my oral cavity is so dry. I need to get up. Every 10 minutes, I need to sip something and then go back to sleep. I cannot sleep because of this. He's completely disease-free. And sometimes they say because of the dryness, I cannot talk. I have excessive salivation, so I always drool. I don't want to go out because I'm drooling all the time. So a lot of issues came out during the study. And when I compared what WHO recommends, it's like, okay, they all need, most of them, 58% of them needed immediate treatment. Where should I refer them for treatment? That was another question. I can refer them to the nearby government hospital, but most of them are very sick to go to a government setting. Most of the dental clinics are either in the first floor or the second floor. People can't climb those steps. Some of them are on wheelchairs. They cannot climb. They cannot afford. I started calling people, can you give free treatment? Can you give free treatment? It's like looking at me, free treatment. What are you talking about? So what I did, I raised fund on my own. I started a dental unit in Pallium India in 2016. Sorry. So by that time, I joined for the postgraduate course in Cardiff University, UK. So I opened a dental unit in 2016. I could convince some of the people, well-wishers, that, see, this is the need. But I don't have the money. I don't have the money to start a dental unit. So basic minimum, a dental chair, and very basic minimum. Everyone donated. Some of my friends donated their not so used dental instruments, some materials and everything. So what I did is that at the time of diagnosis, they had issues. They had pain. They had other oral issues which needs thorough attention. During the disease modifying treatment, so most often when they are referred for radiation, they have to go through the dental prophylaxis. Sometimes they cannot go to the government setting, they cannot afford the private setting, they used to come to me. So I used to get referrals for that. After all the treatment is over, they are disease-free, still they have problems. But they are too sick to travel or to wait in queue. And a lot of end-of-life care situations happened. So as someone mentioned, communication can be done by anyone. Volunteers do communication, nurses do communication. We are much, much qualified than them to do communication. We know the medical terms. We have learned medicine. We have learned surgery. So I think if a nurse or a volunteer or an ASHA worker or a social worker talks about illness, definitely we can do. So I started getting involved. End of life care was something very personal or close to my heart. So I used to spend a lot of time with people who are dying. So I used to have communication sessions, family meetings about the dying process, how the whole dying process can happen, what should be anticipated, what do you mean by chain stocks breathing, what should you do when this happens, how to prepare them for death. And after death, there is a service called bereavement service. After death, family finds it difficult to cope with the situation. So we talk to the family members, make them understand, help them to cope with the loss of their loved one. So I worked in all these areas. I'm not telling what I did. I'm taking you through that journey so that you can understand where all you can fit in. By the time I got a Commonwealth scholarship to finish my master's in palliative medicine from UK, otherwise it is very unaffordable. So during this time, we were working on NDPS amendment, narcotic drugs and psychotropic substances. So again, as I said, when it comes to pain management, how many of us have learned WHO analgesic ladder? When I went to IPM for the posting, the first thing they told is to learn WHO analgesic ladder. What ladder? Then they told there is a 3-step ladder. Step 1, step 2, step 3. So according to the severity of pain, you have to prescribe analgesics. So there we actually got a chance to prescribe analgesic. I saw the change in front of my eyes. How much pain relief is received with one dose. So then I really wanted to learn about the pain management. And we started working on the NDPS amendment. In the amendment, dentists were not included. So we made it happen that any dentist who is dealing with head and neck cancer can stock, prescribe, and dispense morphine or any opioids like fentanyl, morphine, methadone. A lot of opioids are available. So any dentist who has undergone training in pain relief and palliative care, along with an MBBS doctor, okay, under any law for registration of dentist, can prescribe essential narcotic drugs for pain relief and palliative care. And in an organization like Pallium India, where we have reached around 25,000 patients. The current patient care is around 5,000. And one of the license is in the name of a dentist. So my colleague, who is also another dentist who takes care of the clinical service heading. So one license is under her name. So you can understand it is possible. So why are we not addressing pain, at least for head and neck cancer patients? Why are we not assessing? We are not trained. I was not trained to assess. I did not know how to assess pain. What scales can be used? How am I going to document? How am I going to manage pain? All that I learned only after training. And this is what they say. I'll just, I'm not reading the entire thing, but you can apply for this license if you have a registered medical practitioner you can be a registered medical practitioner if you have training in pain and pain management and palliative care. And what all can be done at the what was I doing? I was involved in pain management. I was involved in managing other symptoms also, communication with an empathetic way, preparing them for further treatment and investigations. During the treatment, I used to do prophylactic extractions, scalings, and fillings. Pain management, sometimes toothache is the only problem they have. Nothing else. Management of mucositis during treatment, after treatment, dry mouth. Oral thrush is, you cannot imagine. I have not seen this much oral thrush when I was doing my undergraduate. And the hyperplastic candidiasis is very, very, very common. Not in head and neck cancer, just in head and neck cancer. People who are dying, people in neurological illness, people who are with other progressive illness, everyone has this. Mouth opening exercises and possible processes within my expertise. Communication, because many a times patients drop out because of lack of communication. They need our support. Feeding and nutrition, some of the processes can help. And this is another person who had his treatment. He has a tracheostomy which could not be removed, but his cancer is cured. He is under remission. He is fine. He wanted to get a tooth removed. It was causing a lot of problems. The oncologist did not give clearance. No one is giving clearance, but he told, see, this is what I want. So I used to do these things for him. And this was another patient who was undergoing, he was on end of life care with progressive lesion. You can see how difficult it is to have a tooth hanging out like this. And no one is ready to touch that. I mean, how can how can I refer this patient to somewhere? Who will do? Then we need clearance from this, that, you need to stop this, that. I mean, this is my experience. Even if I refer them to a government institution, a government college, or a private college, usually they come back. Doctor told to get clearance from this. I mean, who is going to give clearance for this person here? He's dying. He doesn't have any primary treating physician. He is at his home dying alone. There is no doctor who can see him and give this whatever clearance that you are asking for. So be humane at that time. We use our senses. This was his end of life stage where we used to do pain management for this particular patient with various methods. It was not just opioid. So he had a very, very terrible time. Can we certify deaths? I think I'll be the person who have certified the most number of deaths as a dentist. A lot of patients die, and if they're dying out of head and neck cancer or infant, during your treatment, you can sign professional certificate reports and other documents. This happened in 2014 in the revised dentist regulations. And then I used to accompany the team who goes for home care with difficult terrains. As you mentioned, someone mentioned that people cannot come to a dental clinic, right? Suppose a wheelchair-bound patient is living in this terrain. He cannot come in his wheelchair to your dental clinic to get a denture fixed or to get an extraction done. We used to do minimal procedures at home. I still have a colleague of mine who goes to home care, do dentures there. So she takes the impression, come back, then she goes with the team, make the fitting there, then she comes back. And we try to provide a sponsor only for the lab charges. Very often she herself do it from her own lab, but there are possibilities which can be done. We are doing that. And this is one example. I mean, he had a severe, he is a person who lives in this area, could never go to a dental clinic because he's wheelchair bound. All the clinics are second floor, first floor. He could never reach there. Many of them denied treatment. He wanted some. What is wrong in getting a good smile? Because you are in wheelchair, you are not entitled to get a good smile. I don't believe that. He was so happy with minimal treatment. He told, I always wanted to get it done, but no one gave me because I'm on a wheelchair. So this happened. It is about bringing smiles. It is not just about pain management or oral lesions or maggots or foul-smelling ulcers. It is also about bringing in smiles. And it is not just about adults. So we have a lot of children with birth anomalies, Down syndrome, cerebral palsies. I know that they can be, I have done treatment to these kind of children when I was in my undergraduate time. But when it comes to children, they are restless. And we are so, many of these patients, when I refer, they are not offered conscious sedation because they are scared. Again, clearance, can we give conscious sedation? So I used to do minor dental treatments for them because I learned pain management. I learned how to use judiciously the sedatives. So we used to do a lot of treatment there. And are we equipped? We really need training, a lot of training. It took me years to talk about palliative care and pain management. And currently, my department is catering to around 6,000 doctors are trained under us. And where am I placed? So people who asked, what is your role? I'm glad that I'm spreading this across the country, across the globe. Under our department, we are training thousands of doctors every year. So we should actually advocate for integrating modules in the UG curriculum. We should talk about communication. We should learn pain management. Head and neck cancers are the most painful ones. The pain starts from the time of diagnosis. It goes on. Even if they are getting curative treatment from a cancer center, the pain will be there. Hypersalivation, xerostomia, oral thrush, everything is there. Even if they have finished their treatment, still the problem exists. So head and neck cancers, definitely yes. Pain management, we should be equipped to do pain management. We should be equipped to talk to patients. You saw something, the patient is ready to open up to you. They want to tell you, okay, I'm scared. When they say I'm scared, we should learn how to respond to it. And for specialist palliative care, we should be linking them to the local palliative care centers. We should have clinical postings. Like I underwent palliative care training when I was an intern from the IPM. Likewise, we should have clinical postings. I'm sure if there are some community dentistry people, they can initiate this, and I'm really glad to initiate that across the country. So I'm just ending my long talk here. With Dame Cicely Saunders is the one person who started palliative care movement across the globe in the UK. And I am very much attached to this code because we will do all we can, not only to help you to die peacefully. So it is not just about death, but also to live until you die. So with that, I will stop my presentation and I'm happy to take any questions.
Hi, Dr. Sreedevi. Can you hear me?
Yes. Hi, Dr. Vivek. Nice to see you here.
Yeah, nice to see you after a long time. Thanks for the presentation. The query that I have is completely agree with you. When do we stop asking for consent? We need a consent from anything and everything to try extract even a grade 3 mobile to do scaling of just removal of soft debris. What is your take on that? Like, I think most of the time it results in more trouble than help at all. Is there, have you faced any issue after going ahead with treatment? Uh, I mean, when do you stop taking consent? You can't transfer the entire risk to that medical person. Sometimes there's just nobody to give you that. So, what is your take on that?
All patients I have treated, I have not taken any consent. We have, what I do is like, I ask a general medicine, and okay, this is a situation.
Ma'am, your audio is not clear. Hello. Ma'am, it's not clear.
It's very
No.
feeble.
Let me disconnect.
No, ma'am, we can't hear you.
Better?
Yes, it's okay.
Yeah, much
Yeah.
better. Much better.
So I usually I call, suppose the patient is on disease modifying treatment. Even if it is in a medical college, I make a phone call and I ask that this patient has come to me. Is there any particular contraindication? They say, no, I am not. I have never asked for any written consent, because the moment you ask, this patient has to go there, stand in the queue, take an OP ticket, stand in the queue till evening just to get the consent. And it will be some different doctor sitting there. Then he has to come another day, giving 1,000 rupees in a rickshaw, come to me and do the procedure. So that is never going to happen. And we have a basic medical background. We have pretty good medical background. We know what to do and what not to do. And the key is good communication. Developing a rapport with the patient is the key. And I'm sure how well we convince patient to do an implant, right? How much chance of failure? It's very risky. It can fail. People will lose lakhs. But we are pretty good at convincing patient. The same skill is needed to develop a rapport with the patient. And it is the same question is asked by the medical doctors. The question is different. But when the patient dies, why are people not being angry at you? Like in our IP, every day people dies because they come for end of life care. We deal with a lot of deaths. Are you not being slammed or flagged or shouted at? No, because we are preparing them. So when they ask for it, I will tell this is the situation. We are doing this in a very compromised situation. I'm not doing this in a hospital or something. And how well you are connected to that patient, that really matters. So the skill that we use for them to do a bridge or a root canal or the implant, that skill can really be used to understand. But if you are concerned about the medical condition, I will always ring up without any shame. I'll call the general medicine people. So I've made friends circle, PGs or someone who is actually available. Is there any actual contraindication? No. Okay. Is the patient going to die because of this? No. That's it.
So I think it's basically your rapport with the patient and brushing up the basic medical topics that we have learned. I understood we are pretty good at it. I mean, we have learned pretty good medicine. It's a very strong background we have, but we don't use it. We are recently, very recently, like 2 months back, a person on wheelchair had a dental issue. Diabetes is uncontrolled diabetes, retinopathy, nephropathy, neuropathy, everything is there, but the diabetes is under control. So I rang up someone very close to me in the dental college and I asked, can you do this for me? So that particular person was on leave on that particular day. This person is living alone. So what I did is like we sent him with our driver. So our driver took this patient to dental college. The driver was there, but that was not enough as a caregiver. I mean, there is no one in the family. He has to undergo it. Right now, my dental chair is not functioning for an year because we shifted the place, and because of lack of space, we have to temporarily shut it down for an year or more than a year now. So I had to depend on someone. Then I got a call, ma'am, you cannot refer patients like this. There is no bystander. I was like, there is a driver, but that is a driver. And of course, he's a bystander. I told you do whatever you want. I am taking the responsibility. Just do the extraction. I will give my consent wherever you want, but just do the procedure for the patient. So there are a lot of difficulties. We say dental college is there right in front of me. Things don't happen because things just don't happen. And it is not patient friendly, to be frank, not at all patient friendly.
Most often, I feel we end up fearing the unknown, like what we do when something happens. And
Yes.
would just like to add a small point that already the curriculum for BDS, luckily the palliative care component has been included. And it's been happening since 2016. Of course, we are all in the learning curve. Probably things will get better. Thank you so much.
Thank you for that information. Actually, we are working with medical colleges. We are training faculties in the medical colleges, like a train the trainers program, so that they can teach, because the message that you convey to the students is very important. Someone who do not believe in pain management, that we cannot do pain management, if that person is teaching palliative care, the message is very different. So same thing we are doing with medical college. Probably we should work with dental colleges to train a few faculty from dental colleges so that the right message is gone. They know what are the legal implications, what should be prescribed, what not should be prescribed, proper pain assessment and communication. Probably that will happen soon.
Hello.
Yes, Dr. Rajman.
Madam, some doctors directly prescribe morphine without going to the pain management. There is a ladder for pain management. Some medical doctors directly given morphine.
So Dr. Ajmal, the pain management, you don't have to climb the ladder step by step ideally. So the pain prescription is done according to the severity of pain. So if I have a patient
it is not under the 4th hourly prescription. Morphine is given only under 4th hourly, but it's not under 4th hourly prescription. Sometimes SOS, sometimes BD.
That is the lack of training is the key
when
there.
the patient came to us, we can't go for the morphine. Then we can start from the beginning, from paracetamol to tramadol.
Thank you for sharing, Dr. Ajmal. Absolutely, it is the lack of training which is making people prescribe morphine, SOS or BD. That happens very often. But if you get such a patient, you don't have to go back to the ladder. We can always, but we should be very thorough and confident in the pain assessment. You should know whether it is an opioid sensitive pain. If you think it is an opioid sensitive pain, then we don't have to go back to the ladder, but we can always increase the dose. But it comes with training. It is better to talk to someone who does pain management and increase the dose. But yeah, that is possible. We don't have to go back to the ladder. But I agree that a lot of medical doctors, we also get prescriptions with SOS or BD morphine. I agree to that. Thank you for sharing the question.
whether any courses, online courses for palliative?
Yes, Dr. Ajmal, if you get a log into Pallium India's website, Senior, would you like to share the screen, our training?
Yes,
So if
ma'am.
you log on to Pallium India's website, there is a training page, and we run foundation courses, which is called Foundation Course in Palliative Medicine, which is open for dentists also, which next batch will be probably in the month of January. It is 20 sessions online, and there is physical sessions of course in Trivandrum and in Calicut and in Thrissur and Ernakulam also. So if you go to our website, you can see a training page. If you go there, you will get to know about all the online training programs that we have. So all these programs for doctors, it is open for dentists. We have written in so there is a self-learning module called Integrated Basic and Advanced Course in Palliative Care, which you can do at your own pace. And we have 7 live sessions with that. And there is foundation courses. If you are more interested in psychosocial part of it, we have a specific course for psychosocial interventions. So all these courses are open for dentists.
What
So
about the
anyone willing to-
charges?
So once you open the link, you will get all the details, sir. So different courses have different fee. So if you can, after the program, if you can click on the link, you will get all the fees for. So the fee is very nominal, sir, and the fee that we collect in Pallium goes to patient care. So the fee is very nominal.
Madam,
Yes,
actually, it's very, it was very interesting, and it was an eye opener for dentists like us. And my request and query to you is, how would you be? How we can associate in Kerala State, in Indian Association to create an awareness about the relevance and importance of palliative care and the opportunities in palliative care for dentists. How will we
I
can?
think this is one big step that you have taken. Now at least around 20-25 people got an idea about how we can do it, right? So maybe each district can have one program or during one of your conferences. So that's what we do for medical colleges during conferences in pulmonology, in oncology. There is always a dedicated slot for palliative care. So probably that is one way to go about it, because you will get students and everyone coming for conferences, right? Even the specialty conferences or general conferences. Maybe one slot, if you can create, it is not just me. We have 2 dentists and 1 volunteer dentist working with us. And there are a few others which I know about working in other centers. So we can always have a workshop, and maybe a core committee can be created to discuss how we can take this forward. In Kerala, there are a lot of NGOs which you can get associated with, which actually needs help. So
we are very open to get in, because we have a plan to. I mean, we have suggested a plan for creating a palliative care brigade in every branches, more than 30 branches across Kerala. So at least 5-6 from a branch would be interested to join it, and I think it's an opportunity for young dentists as well to are really passionate about taking, so there is an opportunity. So we should associate, and
we can continue. We can continue this conversation. Like we can be in touch after this program, and then we can create a model. I mean, all the models in palliative care started in Kerala, so probably this will be a model that we can vouch for, and this can be replicated. I'm sure my organization has the capacity to do such work. We have the caliber to take it up, so we can definitely have the conversation and take this forward.
So, thank you. And the main challenge we would have, we need to get trained the treatment
Yes.
part, basically, the medication part. And that is the area where we step back, So when we approach a patient, so even a mouth cancer patient, if we see for the first time, we give them some ointments, some steroids, and we make it worse. So we tend to make it worse. So we need to have a different thought process or
Yes.
protocol
Yes.
approach towards it. So
At least having a conversation, asking what do they want, what are they going through, what is bothering them, is there any pain? So these are all very important because many of these cases which invariably comes to us.
Yeah.
So that's very important.
right.
We can actually do. I mean, if there is a pretty good number of people, we can do a course specifically for that particular group.
That is what I
Just
was
for
thinking
medical
for a day course, and we should for a day on offline course for a day, so that it can be more.
Yes.
You know.
We can always plan that. So I understand this is IDA Kodungalur branch, right?
Now, this is actually Trichur district, district. All the branches from the Trichur.
Okay.
Taking part. I mean, taking initiative to conduct such program. Yes.
Okay. Like there are a lot of very strong palliative care services in the district of Thrissur. I mean, a lot of institutions providing a lot of models there. So we can easily do one session for sure.
Madam, some years back, there is a course conducted by Indian Dental Association, Kerala State, Palliative, under the guidance of Trichur Palliative Care. So many dentists attended the course, but the certificate not issued.
I am not aware of that, sir. I think whichever institution hosted that.
It's a 2-day course.
Okay.
Dr. Suresh conducted from Calicut.
Okay. That's a very different institution from ours.
Such courses may be conducted by the IDA to promote the palliative training.
Definitely. But what I advocate is that we should not stop with just getting trained. There should be some plan ahead. As you mentioned, every district will have a brigade. That's what we want. We want to reach the patient. There is no point in getting trained and not using that at all. So there should be some way ahead also. If there are no more questions, we can wind it. We can always you can always write to Pallium education website. Everyone's number and email IDs are given. So thank you so much for the patient listening for an hour.
Thank you, madam.
Thank you, ma'am. On behalf of Indian Dental Association, I would like to extend our sincere thanks to Dr. Sreedevi Warrier for her invaluable contribution today. The session was both informative and enlightening. I express our gratitude to Dr. Sebi, Dr. Joseph Sachiv, and Dr. Joji Peter. I would also like to express our gratitude to our IDA members and friends for your active participation. Thank you. Thank you so much, ma'am.
Thank you.